Good evening, sir. कैसा गया exam?
Sir, tomorrow there is exam. Today theory paper checking of Rajiv Gandhi University, whole university.
Oh, how many students?
3 students tomorrow for whole day. And in university there are 20 students, so 20 paper of each. That is 80 papers. 80. 4, 20 into 4.
So how many days you are there?
Tomorrow, sir, practical exam will get over at 6 p.m. and day after tomorrow I will be back to Mumbai.
Okay, so other students will be examined by other examiner.
Sir, there are 3-4 centers probably. So
Okay.
here only 3 students.
So you are in MS Ramaiah.
I am Ramaiah.
Huge campus, huh?
72 acres, that's what they told.
Yeah, it's a huge campus.
I'm first time going to that place, so big campus it is.
Arjun was
But
there.
But it includes all other so engineering, dental, physiotherapy, सब कुछ भी है उसमें.
Correct. So today we will be doing the last OSCE.
Yes, sir.
Next time we have got 3 cases CA bladder. So all like superficial, deep, and metastatic. We will tell Ganesh will take his advice, and if he says, then we may call onco physician in the end, so that we can guide what treatment to be given. So he is answering today.
Good evening, sir. I will be answering, sir.
And who else?
Sir, good evening, sir. Prashant.
Okay, so both of you are answering.
Yes, sir.
Yes, sir.
Anyone? Any third student?
Sir, I think Amit. I'll ask him, sir.
Okay. So we wait for
5-10 minutes and we start.
Yeah, 2-3 minutes and then we start.
Okay.
So I am the third student, so Ojas say. Hello? Yes, sir.
Okay, Ojas.
Yes, sir.
Okay, Ojas. So 3 of you are answering today.
Yes,
People
sir.
are now busy, or I think MCH exams are over.
It's going on, sir. Yesterday, today, Nair Hospital MCH exam was there. Tomorrow, JJ. And probably day after tomorrow, or in same week, Sai 9 KM also.
Okay. So the students are very busy. And DNB up still now the result has not come.
Theory result has not come. Probably.
No, sir.
DNB theories are not come. So we don't know
sir.
when it will be. Shall we start now?
पंकज सर ज्वाइन होने वाले हैं नहीं?
मालूम नहीं. I'll just telephoning.
एक बार फोन करके देखो, नहीं तो शुरू कर देते.
He will join after 15 minutes. So we start then.
So we will start, sir.
Yeah, we'll start. Paras,
Yes, yes, sir.
you start it. Huh?
Prashant, sir, आप.
Yes, yes. I'm listening.
We'll give you 2 minutes, 2 to 2.5 minutes. You see that?
Yeah.
Okay.
Yes, sir.
And then answer. Prashant, you are ready?
Yes, sir.
Okay. So the request to all of you is, please, when we give time, you try to write it down. So in these 2 minutes, you must see, you may be able to answer, but when it comes to writing, it may be difficult. Okay, fine, answer.
Sir, these are the films of the cut section of the contrast enhanced CT scan, CT scan showing kidneys. Sir, right kidneys appears normal, sir. There is on left side, sir. There is a collection, perinephric collection with the disruption of the parenchyma, and probably it is because of the trauma, which is the laceration is communicating with the pelvic system, sir. And how will you manage this patient, sir? Firstly, I will manage this patient with ABC, sir, airway, breathing, and circulation. I will monitor this patient's hemodynamics, see the pulse and blood pressure of the patient. And if he is not IV fluid first, then inotropes and SOS blood transfusion. If he is not stable with this approach, I will do SOS exploration and do the needful surgery. And what is the indication of surgery in this case, sir? Firstly, sir, hemodynamically unstable patients. Then angiography, sir, in case of hemodynamically stable patient which shows extravasation of the dye from the single vessel. In that case, sir, we can do embolization of the particular bleeding vessel, and we can do stenting in case of renal artery thrombosis. We can do, sir, stenting also. Hello. Hello.
Yeah, we are listening. Go ahead. So what can you hear? What is the indication of surgery in this case? 1, 2, 3, 4.
These are three indications, sir. In case of
And what is the role?
yes, sir.
What is the role of
Sir,
angiography?
indication of surgery, sir. Firstly, sir, hemodynamically. Sir, in angiography, sir, in case of stable patient with renal injuries, in which the dye is extravasating from the single vessel, and in case of like CT scan suggest you of renal artery thrombosis, in that case, sir, we can do vascular stenting of the patient and SOS embolization in case of dye extravasation.
Okay. So Abhishek, you are there?
Yes, sir.
You want to add anything?
Yes, sir. Sir, role of angiography would be, sir, delayed arterial bleed, or sir, any case of pseudoaneurysm, AV fistula, post-traumatic AV fistula, sir, or any single vessel bleed, sir, like single isolated segmental artery bleed, or sir, slowly expanding hematoma, sir, which has been
Abhishek,
causing yes.
you people are not understanding what is the role of angiography. That means what? You have done a CT scan. Okay?
Yes, sir.
And
Yes, sir.
now you want to do angiography. So how will you say? How will you find out? So just tell us the indication. What are the indication? What you are telling me are the findings of angiography.
Yes, sir. So, sir, delayed arterial bleeding causing hemodynamic instability, sir. Slowly expanding retroperitoneal hematoma, sir. In those cases, we want to do angiography, sir. And other than that,
So medial location of the hematoma at the hilum. So in that case, we'll have to do an angiography to see if there's an active bleed. And in case of grade 3, where it is subcapsular expanding hematoma, in that case, we'll have to do angiography to know what is the source and do SOS embolization.
So now you have done the CT scan and the left side is not showing any contrast enhancement. Will you like to do angiography?
No, sir.
Why?
So that indicates that the left side kidney is totally non-functional actually, sir. Or as in it is completely, it's grade 5 injury, as in no, it's totally non-functional or a non-functioning kidney.
Non-salvageable kidney.
But it can be because of you don't want to find out whether there is a total disruption of the artery or whether there is hematoma pressing on that. You don't want to see anything.
yes, sir. So there may be a hematoma pressing on the main renal artery, which may be causing the contrast to not reach the kidney, sir. So that can be found out, sir.
So basically, you want to do angiography number 1 if you think that first of all you want to do any arterial surgery or any vascular surgery or any embolization or whatever it is. Okay, so these are the indications. Dr. Gite, your view?
They are mixing the things in this patient. After seeing the CT scan, there is a gross perinephric hematoma with parenchymal laceration at the level of mid-pole, with majority hematoma is on the medial aspect of the kidney. So, and in picture number 4, the left renal artery is clearly seen entering into the kidney. So, as far as the major vessel is concerned, there is no any vascular mishap in this patient. Chances of having a PUJ disruption is there. Chances of having a renal parenchymal laceration at midpole with bleeding from that side may be there. So it is probably grade 4 renal injury with or without pelvic disruption or pelvic injury. So in such cases, describe the finding. This is the finding. How will you manage the case? So we have to shortlist your management in terms of the general management. That is the hemodynamic stability, then confirmation of the other non-urological injuries and their immediate managements, then confirmation of the staging of the renal trauma, then confirmation or requirement of the immediate treatment. So immediate, so we have to choose such the patients who require immediate treatment. So that the management for that particular patient is either immediate exploration, or here there is again, if the patient is getting deteriorated, then there is angioembolization, angiography and angioembolization. It may be for selective renal vessel, it may be for direct major vessel. Also, you can block the vessel and stop the bleeding and maintain the hemodynamics of the patient. So these are the then indication for surgery. So grade up to by current till current literature, up to grade 5 renal injury also can be managed with conservative treatments, provided that there should not be expanding hematoma, there should not be downgoing hematocrit, there should not be persistent and downgoing blood pressure, that is hypotension. These are the some acute indication of exploration. If patient BP, in spite of your conservative management, is not going down, that is one. A palpable, there is hematoma, and that hematoma is expanding and pulsatile, that is another indication for exploration, and downgoing hematocrit. So and associated abdominal surgeries, if there is exploration, and if patient had a grade 4 or grade 5 renal injury also, in such situation also you have to explore the things. So these are relative indication for renal exploration with other 3 what I have told. And what is the role of angiography? Angiography, yes. So number 1 indication to block the selective or main vessel if it is causing or endangering the life. That is one indication. If you want to do a emergency exploration and if CT is suggest of one particular vessel is bleeding, and if you avoid the surgical exploration, then you have to block that particular vessel. So selective embolization, that is one another indication. And a grade 5 injury with all the parenchymal multiple lacerations, and there is a lot of hematoma, then in such situation also, if BP is going down, so to by the time you have to and save the life, you have to go for angioembolization. That's what's my take on this slide, sir.
Yeah, one more thing, because they have asked what is the indication of surgery in this case, and Dr. Gite has very rightly said that this hematoma is in the mid-pole and mainly near to the hilum. So there are also chances of disruption of the pelvic-calyceal system, mainly the pelvis. So there may be extravasation of urine also if the bleeding is also not there. So again, that also merits the exploration.
So whenever any CT shows there is a medial collection or medial hematoma, you have to go for repeat CT scan after 48 to 72 hours, which will, or you have to take the delayed films in same sitting, so to diagnose the pelvic injury.
Fine. Paras, second case. So we'll give you 2 minutes. Prashant, write it down.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
Prashant, you ready?
Yes, sir.
Okay. Go ahead.
Identify the investigation, sir. This is a bone scan. And what is a pharmaceutical agent used for this investigation, sir? It is technetium 99, methylene diphosphonate pharmaceutical agent which is used. What are the findings, sir? The findings are like there is a tracer uptake in, sir, axial skeleton, mainly in vertebrae, and sacrum and pubic bone, and sir, uh, and also in skeleton, suggestive of bony met, sir. What are the terminology used in this finding? The terminologies are tracer uptake.
Okay. Tejas, you know?
So just sir, this is actually sir FDG
What
PET
is
scan.
Ojas? Yeah.
Yes, sir. So it's a FDG PET scan, sir. I would say it's not the bone scan. It looks like an FDG PET scan. The radiopharmaceutical use FDG PET scan was sodium fluoride F18 PET scan. The pharmaceutical agent uses either fluorodeoxyglucose or sodium 18 fluoride. Findings increase activity in the axial skeleton, mainly in the cervical and the thoracic vertebrae. And terminology uses FDG avid, sir. FDG avid disease. Or
Abhishek, what
yes,
is
sir.
your say?
Sir, this looks like a bone scan only, sir.
Yeah.
99 technetium MDP bone scan, sir. And uptake is
Yes.
seen in the
See, in
spine.
the if you see this thing PET scan, it will be the bright,
Of
you know,
tissue.
Yes, sir.
areas, not
Yes, sir.
like yeah. First of all, so and the background will not be like this. The background is usually the
Background
dark
is
color
dark, sir,
and
usually.
Have you
maroon
have
color.
you seen
So
any tracer in the kidney and bladder?
No, sir. Okay.
That is a physiological uptake in the kidney and bladder. Have you seen any tracer in the kidney and bladder?
No, sir. Can't see.
Then what it is called as?
Okay. Nice bone scan. Okay.
No. Then what it is called as? It is not bone scan. It is bone scan, but it is not called as bone scan.
So that is sodium 18 fluoride.
Absence of tracer in the kidney and bladder on bone scan is called as. That's what the third question. What are the terminology used to describe the finding? That's what they may be asking probably. This is a bone scan only.
Correct.
Have you seen any tracer in the kidney and bladder? Just उसको बड़ा करो और देखो, अगर नहीं है तो उसको कौन सा स्कैन बोलते हैं बताओ.
But
So
in
what
the
is
exam,
what is
Yeah, yeah,
mean
tell-
by super scan? So that is common question asked in exam. What is mean by super scan on when the bone scan is called as super scan? Whenever there is a non-visualization of the tracer in the bladder and in kidney, which should be physiologically there, then it is called as a super scan. That is one. Another thing is technetium 99 MDP, that is methylene diphosphonate, is one agent, and another agent is 18 fluoride bone scan. 18 fluoride bone scan. So, what are the drawbacks of 99 technetium MDP scan? MDP agent. So that's why the fluoride bone scan is superior than the MDP scan, and the MDP scan, that's what we usually using routinely to do the bone scan. But it is the bone marrow based bone scan. MDP is a bone marrow based bone scan, and the chances of missing of metastasis. Okay, metastasis, bone marrow based metastasis. It is a bone marrow based, and metastasis can be missed in case of the MDP. But in case of the fluoride bone scan, there is a good soft tissue clearance, and the time required is shorter scan time. The advantage of 18 French fluorides, 18F fluoride bone scan is good soft tissue clearance and shorter scan time. The rest, there is uptake in the sternum, uptake in the iliac blade, whole of the spine. So in the skull. So
Yes, sir.
axial skeleton metastasis. So in answering the bone scan, there you should not hesitate to crumble or humble in between. ये तो रूटीन है, सब एग्जाम में रहेगा. If any doubt, please ask. Otherwise, we will go ahead.
yeah. Abhishek, you want to say anything, add anything?
No, sir.
Okay, then we'll go ahead. Fine. Now Abhishek is answering.
Yes, sir.
So take 2 minutes. Abhishek, you are ready?
Yes, sir.
Okay, fine.
So 18-year-old male underwent surgery for spinal dislocation, presented with urgency and urgent incontinence. UDS is given. So describe the diagnosis in the UDS. So, sir, this appears to be in the filling phase, sir. There can be in appears to be leakage on stress urinary incontinence can be noted, sir, because there is a leakage on every time the patient is attempting to cough, sir. Secondly, sir, what is DLPP? And also, sir, detrusor overactivity can be seen, sir. And sir, what is DLPP? So, sir, it is detrusor leak point pressure. So, sir, basically DLPP is amount of P that required to cause leak in the absence of increased abdominal pressure, increased intra-abdominal pressure. So that is DLPP. So normal is around 40 centimeters of water, sir, and clinical significance is, sir, increased DLPP is an indicator of increased DLPP is an indicator of a deterioration of upper tract, sir. Sir, likely DLPP in this case appears to be, sir, I think more than 100, sir. And what is the long-term problem? Long-term problem is, sir, deterioration of the upper tract, sir, and progressive renal dysplasia, sir.
Yeah, go ahead.
Yes, sir.
So what is likely PLPP?
Sir, appears to be more than 100 in this case, sir. It is exceeding the graph, sir.
Now, what are the long-term problem in this case?
Sir, the most common long-term problem in this case would be, sir, renal dysplasia and deterioration of the upper tract, sir, because of high DLPP, sir.
Yeah, Prashant, you want to add anything?
Sir, I will add, sir, in DLPP, the
Hello? Hello?
Hello.
Yeah, Prashant, I can't hear you. Prashant, are you talking?
Can you hear me, sir?
Okay, you want to add anything or we go ahead with the next slide?
Yes, sir. Yes, sir.
Okay. Hello? Paras, show the next slide.
Yes. Dr. Yasir. Dr. Yasir.
Yes, sir. Yes, sir. Hello.
Hello? So I will give you 1 minute for this and then after that we'll discuss. Okay?
Okay, sir.
Okay, you are ready?
Yes, sir. Hello.
Hello? Yasir, you are ready?
Hello. Yes, sir.
Okay, start.
Hello. Yes, sir. Sir, the ECG shown in the box, sir, is basically the findings are there. We have, sir, tall T waves. Plus, sir, the QRS complex is broad. And the third finding is this, sir, there is ST segment elevation. So this is likely, sir, an ECG of a patient with hyperkalemia. This is the likely diagnosis, and
Okay.
management basically management, sir, includes giving calcium gluconate, 10% calcium gluconate, 10 ml over 10 minutes. One. Second would be, sir, insulin, giving insulin 10 units of insulin over 20 minutes. Sir, and IV, and sir,
So when you talk about the management, hello?
Sir, actually, he got disconnected and left the meeting, sir.
Okay, so Prashant, you say, okay, what is the management in this patient?
Sir, basically, this patient is with hyperkalemia with ECG changes, sir. Firstly, we will give, sir, 10%, 10 mg, 10% calcium gluconate over 10 minutes. And then, sir, insulin and
See, the most important thing is,
5%
listen, Prashant, the
cardiac
most
protocol.
important thing is first
Yes,
you
sir.
are going to collect the blood
Yes, sir.
and immediately send it because you want to know the level, na?
Yes, sir.
And at the same time, you will start the treatment.
Yes, sir. Okay.
So what treatment you will start?
Sir, for treatment, I will start him, sir, IV calcium gluconate 10 mg, 10% over 10 minutes, sir. Then insulin drip I will start, sir. 5% dextrose with 18 units of insulin I will start. And then IV soda bicarb 50 to 100 milli.
And then what will do?
I will repeat the serum potassium, sir, to see whether the potassium is
So you
came
will
to
do the
normal.
ECG and you will repeat the serum potassium or the blood potassium, correct?
Yes, sir. After giving the treatment for the patient.
And then you will see what is it.
Yes, sir.
Fine. Okay. I think there is nothing more in this, you know. We'll go ahead. Paras?
hello.
Dr. Mrigank. Dr. Mrigank.
Yes, sir. Yes, sir.
You are ready?
Yes, sir. So this 55-year-old male with grade 2 BPH and with a PSA of 28. My findings in this trust is there's a hypoechoic lesion in the peripheral zone, and a possible diagnosis would be CA prostate based on raised PSA and symptoms, and also it could be abscess.
So,
Hello.
so what
Okay.
findings you are seeing? Where it is?
So in the
So in the
peripheral
sonography, what
zone,
you say?
hypoechoic
So
lesion,
in
sir.
the sonography is sonolucent or what you say?
Yes, sir. It's a transrectal ultrasonography, sir.
Yeah.
And so zonal anatomy we can draw with McNeil zonal anatomy, showing peripheral zone and central zone and transitional zone with anterior fibromuscular stroma. Name the commonest finding of TRUS in malignancies, sir. In the peripheral zone, sir, maximum hypoechoic lesions. Hello. So can you hear me?
Yeah, we are listening.
So,
Yeah, we are
sir,
listening.
yeah, that is my provision. I mean, like we commonest finding in the trust. Name the commonest hypoechoic.
Abhishek, you want to?
Yes, sir.
Yeah.
So, sir, McNeil's, first of all, sir, give your findings and possible diagnosis. So, sir, there is a lesion seen in the peripheral zone of the prostate, sir, on TRUS. This is a TRUS finding, sir. And this 55-year-old gentleman with grade 2 BPH and PSA 28, most likely diagnosis would be, sir, CA prostate, or it can either be an abscess also, sir. And yes, sir, associated prostate, yes, sir. Draw a diagram to show the zonal anatomy of the prostate. So basically, sir, McNeil zonal anatomy is followed, sir, which is characterized by the urethra with the central zone in the anterior part of the urethra, transition zone in the posterior region, and anterior fibromuscular zone in front of the central zone, sir, and the peripheral zone surrounding these zones, sir. And the commonest finding of TRUS in malignancy would be, sir, hypoechoic lesion seen in the peripheral zone, sir. And which zone is having maximum malignancy? So it is peripheral zone, sir.
Okay. Anything anyone wants to add or any question?
So the commonest finding of TRUS in the
Because these are a
malignancy
very-
is
Yeah.
hello.
Yeah.
Sir, the commonest finding of the TRUS in this malignancy is hypoechoic lesion in 60% of the cases. It is isoechoic in 39%, and in 1% cases it is hyperechoic. And the differential diagnosis of the hypoechoic lesions in the TRUS are, sir, granulomatous prostatitis, and second common is, sir, this infarction. CA prostate, granulomatous, and, sir, infarct of the prostatic infarction.
Okay. Fine. So I think these are the very specific things questions asked, and I don't think that in trust they will ask anything more than these things. So the next question is that once you see this, what is the next investigation of choice?
Sir, based on this, we can either we better go with MP-MRI and followed by biopsy, fusion biopsy or such.
Okay. So how many biopsies you will take?
So minimum 12 core biopsy we should take in and target 12 cores.
Okay. Fine. So Paras, go ahead. Next slide.
Dr. Ojas.
Yes.
Mriganka, just to see this.
Yes, sir. So,
Write it down.
48-year-old
Yeah,
diabetic
you're ready,
female
you can say.
to SIG condition.
Who's-
Findings are, sir, in the right side, it looks like emphysematous pyelonephritis because gas is seen involving the perinephric and collecting system and parenchyma as well. And so my diagnosis is emphysematous pyelonephritis. The predisposing conditions would be diabetes, infections, obesity, immunosuppression, and obstruction, obviously. So my management would be to maintain proper hydration, give proper antibiotic coverage, get a urine culture and blood culture, followed by to decompress the system. We can either do a degestenting or a PCN, and if condition doesn't improve even after that, we might have to resort to nephrectomy, provided the other kidney is working. So proper diabetic control, antibiotic coverage, hydration, and decompression of the affected kidney.
Fine. See, in this case, what is the management? So in this case, you have to talk about yes, antibiotic
Broad spectrum antibiotic. Yes.
Hello.
Hello, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Audible now.
Yes, sir, audible.
Yeah, so you already finished the anything else you want to add?
So we.
So be stage 3.
Hello.
Sir, we
So the
can hear you.
management will be based on the CT findings and the CT
We
classification.
can stage it, no, sir. We can staging,
We
sir.
can
This will be
stage
stage
it.
3, sir.
Home classification, so, because it is involving perinephric and parenchyma and also collecting system and unilateral, so it would be great.
It is in the perinephric, not going beyond. Actually, it looks like perinephric only, sir. Not
Peri, yes.
three.
Actually, it is
So stage
paranephric, better to grade 4, sir. Yeah.
Grade 3 only, sir.
actually, it's paranephric. Stage 4, sir. Stage 4.
Yes,
It's paranephric also. Stage 4.
In
Yes, sir.
stage 3 only.
Stage
Stage
4.
3B only. So in
Yeah, it
stage
is
3,
going out. See, I am not able to hear the voice properly. Something is wrong in my instrument. But as you can see, it is going beyond the, probably the capsule has been, stretched, but it is going out also. As you can see in the first.
Stage 4.
yes, sir.
Yeah,
Stage 4.
so
It's
it is
stage
stage
3
4.
only. Sir, it is stage 3 only. Stage 3 is divided into stage 3A and 3B.
3 and 3B.
3A
It is,
is the perinephric and
Perinephric.
stage B is the paranephric. So it will be
Paranephric.
stage 3B.
3B. Yes, sir. 3B. Stage 3.
3B.
4 is
4 is
bilateral,
the
sir,
kidney
which is
4 is
unilateral,
bilateral.
Sorry,
solitary
3B, sir.
kidney or
3B.
the
hello.
yes, sir.
Sir, we
Yes,
can
sir.
hear you.
Okay, Paras, go ahead. Show the next one.
This was the last one.
So OSCE is over.
Yes, sir.
Okay. So all these things, anyone wants to ask any questions? Is it if someone asks you in this type of cases, all of you have written down your answers. You have tried to
Yes, sir.
write down in 2 minutes.
sir.
Yes, sir.
Okay, fine. So next time we will take only 3 cases. Okay, malignancy, and we'll request Dr. Ganesh. So he will come and he will finish it off. So if your exams are nearby, let us know. Then we will stop, because just before the exam, we don't want to
Not yet
put
announced,
you all
sir.
in a
Theory.
stress. Okay.
Right, sir.
Okay.
sir.
Okay. Fine. Good night.
Thank you, sir. Good night, sir.
Thank you, sir. Good night, sir.
Thank you, sir.
Thank you so much.
Thank you.
Good night, Gaurang sir, Gite sir.
Good night. Good
Good
night.
night, Gaurang sir. Good night, Gite sir.
Good night,
Thank
Hiren,
you.
sir.
Good night.
Good night, Hiren sir.
Good night.
Good night, sir.